Hello everyone. Today I'll be talking to you regarding two very important topics, rickets and osteomalacia. And rickets is a disease of the children and osteomalacia is the disease of adults. But basic pathophysiology remains the same. Okay, and I'll be including all these subtopics which are relevant to my talk. Well, before I start, because this topic need discussion about calcium, phosphate, PTH also, and regarding this metabolism of PTH, calcium and phosphate, this I already have covered in great detail that you can see in my lecture on parathyroid gland part 1. So today I will be talking to you regarding metabolism of vitamin D, and this you can see in my previous lecture. So before I really talk about the topics, let me discuss some very basic a part of the long bone. Okay, that is very essential to know, and you should know what the difference between a growing bone and the fully grown bone. Otherwise, you will not understand ricket and osteomalacia. Broadly classify, if you talk about parts of the long bone, we classify into three categories. First part is epiphyses. They are at the end of bones, long bone, of course. Similarly, we have a metaphysis, or you can say just below the epiphysis, metaphysis, and the in between the two is diaphysis, which make the shaft of the bone. So when we talk about shaft, means we are talking about diaphysis. Well, the first, second and third, very easy, and point to be noted, there is a single shaft diaphysis, but there are two metaphysis and epiphysis. They are at the two ends. Let's talk more detail about metaphysis. So this was a fully grown bone. This is what I showed it, fully grown adult bone like your and mine. But in children, there is one difference is there. Let me focus on that difference only. We have a epiphysis, we have a epiphysis, we have a diaphysis, yeah. But we have a in metaphysis. Now there is one difference. Metaphysis, we have a growth plate, right? What we also known as epiphyseal plate, but it is a part of metaphysis. It is this growth plate which keep on dividing, and ultimately the new bone is formed, which get calcified, and this is how the bone growth occurs. So remember that in the children this growth plate will be there, but once the child has attained the full growth, and this will get fused, so finally we'll be getting like this. Okay, so now you can see, if I enlarge this picture, here we are getting growth plate between the epiphysis and epiphysis, okay, and of course it is a part of, you can say, between the part of metaphysis, and here we are not getting any uh, growth plate, it is fused. And the problem, if it occurs before what we call as rickets, the problem of the bone which occur after growth is so called osteomalacia. So we are clear about the structure of the bone. Now let me talk more about metaphysis, which is the most important point as of now. So in metaphysis is the neck portion of the long bone between epiphysis and diaphysis. As I've shown you, it lies between the epiphysis and diaphysis. The diagram is with you. It contains growth plate. As I told you, it is this part that grows in childhood, and as growth occurs, it ossifies near the diaphysis and the epiphysis. That means whatever bone, extra bone is getting made by the growth plate, it get ossified, and this is how the bone growth occur. So friends, the key word to be remember here is we have a Only keyword, it is the growth plate which divides. Growth plate which divides and which get ossified. This is how the bone is formed. So what we learn, three parts: epiphysis, metaphysis and diaphysis. Point number one. Point number two, growth plate lies in the metaphysis, and it is that which keep on dividing, make the new cell, and these new cells, they get calcified. They get calcified. Point to be noted is the new bone which get calcified and ultimately bone grows. This is normal physiology. Okay. With this background, we still now we'll talk about the point which we say in the new bone formation, cells are being made by the metaphysis, but ultimately it has to be calcified so that the bone become solid. So let's talk about normal bone growth and mineralization depends on the availability of the calcium and phosphate. Point to be noted. Ultimately, new cells are being formed. They have to be calcium phosphate should be there. So for mineralization, what we need? Calcium and phosphate. They are the inorganic part of the bone. Okay. So cells are getting made by the what? Metaphysis, but they are not getting mineralized. So what will happen? Deficient mineralization. Why? Calcium and phosphate are not there. Well, again, I can give you day-to-day example is there. Calcium and phosphate, they just are nothing but cement. We all know big buildings are made. Yes, they are made of bricks or stones. But these brick and stone, they are held together by the cement. So cementing material in the bones that contain calcium phosphate. So I can say calcium phosphate is just like cement in a building, and if you make a building without cement, then wall is not strong because they contain no cement, and that wall will fall immediately because it is not solid, it's not consolidated. Exactly same thing here also. The calcium phosphate is not there, so whatever bone will form, it will be a weak bone. And weak bone can very well bend also. Weak bone can very well bend also. That's the basic concept that you have to understand right in the very beginning of the today's lecture, so we are clear about it. So we understood the problem is impaired mineralization. So again, in the beginning I told you rickets occur in the children and the osteomalacia occurs in adult. In ricket is bone pain and deformity. Point to be noted. Very important point. It is bone pain with deformity is rickets. Exactly same thing is osteomalacia, but there it's bone pain with muscle weakness. Point to be noted. Bone pain is there in both the condition, but in children deformity because the bone is weak. Why? Well, this problem is occurring at the when the growth plate is working. But as I told you, osteomalacia occur when the growth plate has already gone. It is fused. So now it is more of a muscle pain will be there. Muscle pain can be there in ricket also. Okay, but bony pain is the classical thing that we see in both, and muscle weakness more in the osteomalacia. Okay, so now one more thing that in case of rickets, there is deficient mineralization of the growth plate, and that's why the problem is leading to bone deformity. But in case of osteomalacia, impaired mineralization of the bone matrix. Point, this is the basic crux. This you should know very well. These two lines worth $1,000,000. So in both the condition there is bony pains, but in case of ricket it's a deformity is there because the problem is deficient mineralization of the growth plate. But in osteomalacia, it refers to impaired mineralization of the bone matrix is involved. Now come the $1,000,000 question. not known to 99% students. They can occur together also. Something very interesting to talk about. So, in children, when the growth plate is there, and the child is deficient in vitamin D, so due to impaired mineralization of the growth plate, patient can have rickets. And at the same time, even in the bone also, bone matrix, it may be impaired mineralization. That means even osteomalacia can occur. So we get a border zone patient where we can have both. Point to note it very carefully. So now you understood the importance of learning the basic concept. So in rickets, problem is defect in the mineralization of the growth plate, and in osteomalacia it's a defect in mineralization of the bone matrix. Okay, with this background, now only osteomalacia will occur after the growth plate has fused as in adults. Now I don't need to elaborate more on this point. With this background of basic, we still continue with basic. Now we learned about problem is the defective mineralization, and we also know that the two more important component of mineral are calcium phosphate, that we know very well. So now this defective mineralization can occur if there is low calcium, so-called calcipenic, or when the calcium level is reduced. Okay, or they can be caused by hypophosphatemia, so-called phosphatopenic. So point to be noted, if this is deficient, it can lead to rickets. If this is deficient, it can also lead to rickets. If both are deficient, the more severe type of problem will happen. Point to be noted is not only the calcium deficiency which can lead to problem, phosphate also, and it has a very relevant meaning which I am going to discuss later on. So as of now, remember, this can be hypocalcemic or hypophosphatemic rickets can be there, right? Now let's talk about vitamin D, basic physiology. Vitamin D, we have a D2. This is ergocalciferol, and it is ingested from the plant. Point to be noted. Now D3. D3 is known as cholecalciferol. We are talking about biochemistry of vitamin D. You can write down biochemistry of vitamin D. So cholecalciferol is D3. D3 we can consume, we can get directly also what we take in milk. Milk is a very good source of vitamin D, and it is in the vitamin D3. That means it in the form of cholecalciferol. And sun exposed skin. So point to be noted as that sun is the best. In fact, 90% of the vitamin D naturally is made from the sun exposed part. And again, the basic concept in the skin, which part of the skin? Stratum basal. Very frequently asked question. I'll show you a picture of this also. And ultimately, when it is cholecalciferol is formed in the skin, it comes to the liver. So skin in the, it comes to the liver. In the liver, it is converted into 25 hydroxy cholecalciferol. That means in this there will be addition of 25 hydroxy cholecalciferol will be added to cholecalciferol. This is made in the liver, but now it goes to the kidney. In kidney, this 25 is converted into 125, and this is known as 125 dioxy D3, so called calcitriol. Point to be noted, this is the stored form which is made in the liver, and it is the active form which is being made in the kidney. Point to be noted. In the liver it is 25 hydroxylation, in kidney is 125 dihydroxy cholecalciferol. Now 25 getting converted to 125 dihydrocholecalciferol. In this step, what we need is PTH. And in this step, we need an enzyme 1-alpha hydroxylase. This is very, very important to know. Make a box of this line. Make a box of this line that PTH is needed in this particular step. Okay, and 125 hydroxylase enzyme is essential. Okay. Now let me give a applied also. Suppose there is now the clinical applied. Clinical applied. Suppose there is one patient who has got chronic renal failure. Kidneys are not working. Okay, the kidneys are not working, so this reaction cannot happen. Why? This reaction occurs in the kidneys. Kidney not functioning, so this reaction will not happen. Body will try to secrete more and more PTH so that it will try its level best to convert 25 to 125 hydroxylation. And that's the basic pathology in chronic renal failure. In chronic renal failure, what is also known as renal osteodystrophy. Renal osteodystrophy. Renal osteodystrophy. So the kidney is not functioning, this will not happen. Body will try to secrete more and more PTH, and this is known as secondary hyperparathyroid. Now this secondary hyperparathyroid has occurred. Excess PTH, it will try to make vitamin D as much as possible in the kidney, but don't forget the high amount of PTH will withdraw calcium from the bone. If you try to take out calcium from the bone, calcium and phosphate will body, you try to take out from the bone. But what is going to happen in the tubules, in the renal tubules? This high amount of PTH, will try to absorb calcium, but it throws out phosphate. Point to be noted. I repeat again, this basic concept you should understand very clearly. So let's come back to the basic. The topic of discussion is basic concept about renal osteodystrophy. So this vitamin D is not getting made. So they lead to deficient vitamin D. Deficient vitamin D will lead to what? Low calcium level. Low calcium level, definitely. And now body is trying to secrete more and more PTH. This more PTH in a case of CRI will try to make as much vitamin D as possible. The one thing is low calcium, but body will try to secrete more and more vitamin D. Point number 2, but this excess PTH will be acting on the bone, will try to withdraw calcium and phosphate. That means it is going to demineralize the bone. Excess of PTH is causing to cause demineralization of the bone. This is point number 2. But in the tubule, excess of PTH will try to absorb calcium, but phosphate goes out. So that lead to low phosphate level. Low phosphate level it try to. Okay. Remember so in this case, especially in primary, this would happen in primary. In case of primary, excess of calcium and low phosphate level happen. But in secondary variety, low calcium and high phosphate occurs. In secondary hyperparathyroid, low calcium and high phosphate happen. What the mechanism, this you can see in my lecture on hyperparathyroid. The difference between primary and secondary, this is happen in secondary. In primary hypercalcemia, low phosphate level is there, right? So now why phosphate is retained in secondary? Because kidneys are not functioning. So this phosphate is not able to go out, in secondary because kidneys are not functioning. So they lead to phosphate retention. So they lead to phosphate retention despite high amount of PTH. They lead to high phosphate retention in kidney failure because kidney is not functioning. In primary hyperparathyroid, low phosphate because increased secretion of phosphate occurs. So I hope you understood the basic concept why hyperphosphatemia occur in secondary and why hypophosphatemia occur in primary. So we are clear about the basic concept, right? So a quick recap. Vitamin D2 is what we get from the plants. D3 cholic, so this is calciferol. This is cholecalciferol. D3 is cholecalciferol. Then D3 is converted into 25 hydroxycholecalciferol. Then it is converted into 125 dihydroxycholecalciferol, what you call as calcitriol, which is the active form, which is needed for all the body action. And I told you sunlight is the most important. 90% of vitamin D is actually made by the sunlight, and in the skin it is made by the stratum basal. So let me tell you the basic concept about histology of the skin also. So in the histology of skin, we have a epidermis and dermis. Okay, epidermis and dermis. So in the epidermis, we have a stratum corneum, stratum lucidum, stratum granulosum, spinosum, and the bottommost is basal. It is the base, bottommost base. It is this layer. It is this layer which makes vitamin D a commonly asked question. So you are clear about the histology. Histology, you are clear about it. And it is the stratum corneum which contain the dead skin or keratinocytes. They are in the stratum corneum. And the basal is basal which makes vitamin D. Okay. Well, in stratum basal there are Merkel cells which have tactile disc which have a sensory sensation, right? So as of now I'm concerned with vitamin D. So it's the stratum basal is because makes the vitamin D. With this background of anatomy, we still talk more about vitamin D. We learned about various types of vitamin D2, D3, 25 and 125. So this causes increased calcium and phosphate absorption from GIT, point to be noted. So when the vitamin D deficiency will be there, so both there will be reduced calcium and reduced phosphate reabsorption will occur from GIT. Okay. So vitamin D deficiency, especially in nutritional variety, point to be noted. Vitamin D deficiency due to nutritional deficiency, it causes decrease in serum phosphate also because GIT is not absorbing phosphate. But at the same time, of course, in the vitamin D nutritional type, low calcium and low phosphate occur. This question come in all the exam. In nutritional type of vitamin D deficiency, there is low calcium and low phosphate, but it will lead to increased PTH, and this lead to a type of secondary hyperparathyroid. It lead to secondary hyperparathyroid. Okay, so GIT, less amount of calcium phosphate not getting absorbed, understood. So in that case, blood calcium and phosphate both will go down, and this will lead to what? Increased PTH secretion. This is known as, I told you, secondary hyperparathyroid. Now, in this nutritional variety, kidneys are working normally. So, increased PTH will try to secrete phosphate into the urine. So, there will be further loss of phosphate in the urine in nutritional variety of secondary hyperparathyroid. So, phosphate level goes down further. Point to be noted, in chronic renal failure also there was secondary hyperparathyroid, but this secretion is not there. Not there. Why not there? Because kidneys are not functioning, though in chronic renal failure phosphate is retained, and that's why it leads to hyperphosphatemia. Okay, so friends, decrease vitamin D, decrease calcium level, increase PTH, and that lead to reduced serum phosphate level in nutritional variety. Hyperactivity of osteoblasts lead to increased alkaline phosphatase. Point to be noted, in usually in Rickets and Osteomalacia, osteoblastic activity is increased, and that lead to increased alkaline phosphatase. Now, suppose there is excess of vitamin D is there. So what will lead to hypercalcemia, hypercalciuria, and that lead to loss of appetite and stupor also, and it also lead to polyuria. So a question only for the student: why polyuria occur in these patients? Okay, write down in your copy why polyuria occur in a case of hypercalcemia. Quickly, only for students. Well, I'm sure you have written the answer. Answer is due to nephrogenic diabetes insipidus. Okay, so tubules become resistant to action of ADH. Detail you can very well read in my lecture on pituitary gland. Something very commonly asked: there are in granulomatous diseases, there can be hypervitaminosis D, because all granulomatous tissues like tuberculosis, like sarcoidosis, etc. Any granulomatous disease, they lead to increased activation of vitamin D by the epithelioid macrophage. They tend to make more and more vitamin D. This is very frequently, especially in relation to sarcoidosis, which makes increased vitamin D. Of course, increased vitamin D can also be due to because sometimes patient can take more and more tablets. Okay, each tablet of vitamin D consists of 60,000 international unit. Okay, you ask the patient to take one tablet per month, and they keep on taking daily, and that can lead to iatrogenic type of hypervitaminosis D, although it's not a common, but it can happen. So point to be remembered in that in case of hypervitaminosis D, it can lead to loss of appetite, stupor, altered sensorium, headache, and polyuria can occur if high amount of vitamin D occurs. So this was the basic concept. Okay, a lot of things have been covered up. So now I will talk about rickets and osteomalacia. Even osteomalacia is almost same as rickets. The basic concept remain the same. Causes remain the same, bearing few things. Most of things are same. So we'll talk in much more detail about rickets. So now, what is the definition of rickets? It's a disease of infancy and childhood. Point to be noted. Why? It is occurs before the growth plate closes. That basic concept we suffered, and growth plate is active in children and infancy. So that disturbance of calcium and phosphate metabolism. Why? These two are needed for mineralization. So children and infancy, growth plate is there. And calcium phosphate, they are needed. They are the main mineral of the bone. Okay. So if the calcium and phosphate is not there, it's a defective mineralization of the growing bone. That point I discussed, but still I wanted to cover it in their definition. So key word is infancy and childhood, calcium phosphate of metabolism, defective mineralization of the growing bone. Age 6 months to 3 years. And this is also known as infantile rickets. Definitely starting at the age of 6 months, infant is up to the age of 12 months. So starting at 6 to month to 3 year is infantile. It is very rarely seen before the 6 month. Rarely, it's not a common. And that is known as rickets achondroplasia. So main age is 6 months to 3 years. Rarely before 6 months, so-called ricket achondroplasia. And it may occur later in the older children also, maybe 7-8 years. This is known as rheumatic tarda. But again, it is very rare to happen, seen only in famine condition or maybe in vitamin D deficiency resistance. So by and large, what you have to remember, only one keyword. That keyword is 6 months to 3 years. So-called infantile rickets. So practically whenever we talk about rickets, that means we are dealing with a child between the age of 6 months to 3 years, so-called infantile rickets. How we really classify? Okay, it can be nutritional type of rickets. I'll be talking detail about each one of them, but first let me give you the list. What are the classification? Vitamin D resistant rickets, vitamin D dependent type 1 or D dependent type 2, or renal rickets, so-called renal osteodystrophy, about which basic concept I already discussed with you. This is renal osteodystrophy. Okay, let me briefly tell you, we have vitamin D dependent type 1 and type 2. In type 1, there is inability to hydroxylate, and in type 1, in type 2, receptor is age sensitive. Just write down detail, I'll be talking to you later on. So a quick recap. It can be nutritional. It may be vitamin D resistant. Then we have a vitamin D dependent type 1, vitamin D dependent type 2, and of course renal rickets, so-called renal osteodystrophy. With this background, we talk about what are the causes. Lack of sun side exposure. It is the most common causes in the affluent countries. The reason being, okay, nowadays sun exposure is very minimal. Even countries like India or subcontinent countries where the sunlight is in plenty, okay, still we hardly get any sun exposure. Why? You want a home with the AC. You come out of your house, you enter AC car, then you come to office or classroom, AC, air condition, and air condition. We hardly have any sun exposure, and that's why even in the affluent families in even country like India and subcontinent, 80 to 90% people are vitamin D deficient. Why? In less exposure to sunlight. Well, I always say not everything is for exam, but we have to learn practically also. Well, everybody is busy, but one advice which I give in all the classes, previously also I have told you, that at least when you are reading the newspaper, you are taking you are taking your bed tea, that time you can very well go to any place, maybe rooftop of your house or maybe nearby park, depending on wherever you are. So you can get a sun exposure to some extent. Okay. And one more thing I like to highlight, now lot of disease, what they say, hypertension, vitamin or multiple sclerosis and diabetes, etc., all are supposed to be due to vitamin D deficiency. Maybe down the line after 10 years, two things will change. One is the alkaline pH, the blood is essential because it's the acidic pH of the blood which create a lot of problem and vitamin D deficiency. So now the concept is coming regarding alkaline pH of the blood and good vitamin D in the blood. Anyway, this is extra knowledge, not for your exam, just to inform you that you should get sun exposure as far as possible. Well, nutritional is the second cause, very important cause, is common in developing countries. And dietary deficiency lead to, definitely, as I told you, decrease in calcium absorption. Because why? Vitamin D is deficient, and vitamin D is essential in such cases. Low calcium and low phosphate will happen, so-called nutritional type of hypocalcemia, but PTH level will be high, as I mentioned in the pathophysiology. Okay, increased PTH. Malabsorption, any condition of steatorias like celiac disease. Why? Because we need fat. Vitamin D is a fat soluble vitamin, so we need bile salt, and if the fat is not getting absorbed, that lead to steatoria. Steatoria will lead to all fat soluble vitamin deficient, including vitamin D. Surgical condition like gastrectomy and small bowel resection, they all will lead to vitamin D deficiency. Hepatobiliary condition like extrahepatic biliary atresia or maybe primary biliary cirrhosis, all will lead to steatoria, and when they lead to, so any condition, maybe in the children like extrahepatic biliary atresia or neonatal hepatitis or cystic fibrosis, they can cause in children, of course, which can lead to vitamin D deficiency, which can lead to rickets, but these diseases in the adult, they lead to osteomalacia. Prolonged anticonvulsant therapy can lead to vitamin D deficiency. Renal, about this I'll talk later on regarding drug induced renal causes. This can occur due to, first of all, because of reduced vitamin D synthesis. Yes. Now there can be additional thing, defective absorption of phosphate through renal tubule. Defective absorption, and this what happen in X-linked dominant ricket. This very frequently asked question. As of now, just write down X-linked dominant. We have read about X-linked recessive diseases, but we are talking about X-linked dominant. This question itself comes like this: which of the following is a X-linked dominant condition? That is hypophosphatemic ricket. About this I'll talking in detail later on. Fanconi syndrome, where there is defective reabsorption of everything from the PCT. So in these conditions, there will be glycosuria, there may be amino acid urea, there may be phosphate urea. So everything is lost because the proximal tubules are not functioning. Renal tubular acidosis, again type 2. Oncogenic rickets, this again I'll be talking to you little later on. Okay, so all these, they lead to so-called low level of phosphate, can lead to. In addition to that, low intake of or absorption of phosphate in the GIT can again lead to a type of, it's nothing to do with the renal, but just to inform you, low phosphate intake, this again type of nutritional problem. So nutrition also, low phosphate nutrition can lead to hypophosphatemia. So friends, as far as the keywords are concerned, X-linked dominant, Fanconi and renal tuberculosis, and oncogenic. There are 4 keywords. All these I'll be talking to you in more detail later on. With this background of so-called causes, let's see what are the clinical features of a case of rickets. Early features. Remember, the age is 6 months to 3 years. Let's take a child of 2 years. Muscle weakness, lethargy. Okay. Child is malaise. How do you know? Normally a 2-year child is very naughty. He is running around here and there. But you find this child is just lying at one corner. And it is mistaken that child is a very cool child, but we miss it, that it's not a cool child. He's not having malaise, or because of what? Vitamin D deficiency. Sometimes the child may be very extra irritable also. Tetany and convulsion can occur, this all due to hypocalcemia. Hypocalcemia can lead to tetany, is abnormal contraction of the muscle. Convulsion can occur, especially in the newborn child. Repeated diarrhea can be a manifestation of this patient. Point to be noted, hypercalcemia lead to constipation, but low calcium can lead to diarrhea. Late feature. The late feature are when the patient start developing bony abnormalities. Let us see what all abnormalities occur in these patients. In the head, there may be frontal bossing. This is a very, very important question. Frontal and parietal bossing can be there. There may be enlarged head may be there. Vertex and occiput flattening, like this become flattening. So it gives rise to a type of square appearance, so-called caput quadratum. You can see like this. A type of square type of appearance is there. Caput, so-called caput quadratum. Delayed closure of the fontanelle, very, very important point, that again indicate vitamin D deficiency. Skull become thin and soft, so-called craniotabes. This is the universal question. Okay, craniotabes is the feature. What happened? You slightly press the bone, it will become like this. Okay, but you leave it, it again come back. So just like ping pong ball of table tennis, you slightly press it, it will get compressed, but you leave it, it may again come back. So this all what we see in. So important point to remember is frontal bossing, caput quadratum, delayed closure of fontanelle, and craniotabes. These are the 4 keywords to be remembered in this particular slide. Now we talk about chest. So in the advanced stage of rickets, there can be ricketry rosary. This is a very, very important point, and there can be Harrison groove. So what happened? The costochondral junction, they become enlarged. So this is the sternum. This is sternum. And here come the costochondral junction, and it become enlarged. And this is known as ricketry rosary. Similarly, if you look into the lateral side, you get a Harrison groove is there. You can get a groove, so-called Harrison groove. There can be chest wall abnormality. It could be pectus carinatum. Okay, so the chest wall, chest tend to be bulging outward. Chest bulges outward, so-called pectus carinatum, and there can be thoracic asymmetry. Since there is a problem in the chest wall, so these patients are prone to recurrent chest infection, and due to recurrent chest infection, atelectasis can occur. But as far as vitamin D deficiency causing chest deformity, don't forget these three words. The three words are rickety rosary, Harrison groove, and pectus carinatum. The three keywords in this particular slide. Abdomen, so-called protuberant abdomen, so-called pot belly abdomen. Very frequently asked question. You can see the total there is protuberant abdomen is there. Why? Because of hypotonia of the abdominal muscle. So abdominal muscle are weak, hypotonia. That's why they tend to bulge out, so-called pot belly abdomen. Spine, there can be kyphosis, scoliosis. There are so many deformity that we saw in the thorax, but in the spine there can be kypho, scoliosis. Kypho is bending forward. Scoliosis is bending sideways. Pelvis compressed transversely and inlet is narrowed, is what we can see in pelvis. Okay. Extremities. Alignment of wrist and ankles. Knee due to growth plate widening. Why growth plate is widening? Because there is no mineralization. The growth become widened. Okay. And that can give rise to varus or valgus deformity. The leg may move inward, so-called varus, or it may go outward. Valgus abnormality can be there. There may be anterior bowing of the tibia and femur, and it may be bowing forward, anything. What you can say, bowing or bending of the bone. Simple. If I have to give you only one word, bending of bone occur, any bone. Especially the leg bones are more likely to get involved. Coxa vera, this you should know. So this is normal femur and head. This angle is somewhere around 120 to 140. This angle get changed. It may be less, like 105, less than 120. We call it coxa vera. Or it may be more than normal, what we call as coxa valga. So this angle may get changed. It can be coxa vera or coxa valgus. Let us see what are the other abnormalities that we see in these patients. Incomplete fractures, because the bones are very weak, so they may have fractures very commonly. Growth restriction, why? The bones are not growing, the height will be retarded. Delayed dentition, because calcium phosphate is needed for dentition also. Caries and so enamel hypoplasia, why? Because calcium phosphate is needed for enamel formation. Well, in addition to that, there can be feature of hypocalcemia, which can manifest as tetany, seizures, or stridor due to laryngospasm. So there can be tetany is abnormal. Hyperexcitability of the nerves. Nerve is hyperexcitable. With the result, corresponding muscles will contract. There will be abnormal muscle contraction, and that's what we call as tetany. Seizures are very common in the newborn child because of hypocalcemia. So friends, there can be incomplete fracture, there can be dental problem, and there can be tetany and seizure. They are the three keywords to be remembered in this particular slide, 1, 2, and 3. How we diagnose this case? Of course, we have a patient history, examination, etc. That is done already. Now, how to diagnose? Let's talk first about biochemistry. Calcium is low, but sometimes it may be normal. Usually no, low, but sometimes it may be normal. But phosphate is typically reduced in rickets. Typically. So low calcium, low phosphate, that lead to rickets. ALP, alkaline phosphatase level is high because problem is in the mineralization. Problem is not in the growth plate. That is dividing. Growth plate is dividing, and whenever the growth plate will divide, ALP level will increase. A alkaline phosphate level is a marker of the bone growth. Okay, or you can say it is a division of the growth plate. Urine calcium may be low. Why? There is no calcium in the blood. There will be low calcium in the urine also. We like to go for 24 hydroxylase assay, but this we do only for those which are so-called vitamin D dependent rickets, not in a routine test. Similarly, 25 hydroxy vitamin level can be checked. This is a routine test that we do advise for a patient of vitamin D deficiency. Biopsy can be done, but usually it's not done. Very rarely, maybe for academic purpose. Normally, biopsy is not the thing. This is good enough. In fact, the clinical examination itself is good enough. We can go for biochemistry just to reinforce our diagnosis. But biopsy is no indication, no need also. Now, what are the radiological picture that we can see? First and very commonly asked question. Earliest X-ray abnormality is in the lower end of ulna and radius. Cannot afford to forget this line. Ulna and radius, or we can say, what we can say this way also. Earliest abnormality in the wrist joint. Other way around. It means if you have to advise for radiology, what you will say X-ray of the wrist joint, the clinical blind. X-ray of the wrist joint is first to be done in these patients. Now, what changes you get in X-ray in general I am talking about? Let's learn the basic concept. So, what we get is not able to calcify the intracellular matrix. That we have understood. The problem is in the mineralization. So, inability to calcify the classical question. Right? If bone is not able to calcify, so what happened? So what you are going to get it in epiphysis, wide and irregular. Why? So this is the epiphysis, this is the growth plate, and this is the part of metaphysis. So normally it keep on dividing and it get calcified. Here it is constantly getting multiplied, but is not getting calcified. So here is the epiphysis and here is the metaphysis. So you are getting wider growth plate. It is normal. Problem is in the calcification, not in the division. So wide and irregular type of epiphysis will be there. In proliferative zone are active, but piled up irregularly zone of calcification poorly mineralized. So whatever cells which are there, they are not getting. So nutshell is wide and irregular epiphysis. That's all. This is the only keyword that you got to remember: wide and irregular epiphysis. In the metaphysis, the tuberculae are weak, thin tuberculae will be there. Okay, and they become weak, and metaphysis again become broad and cup shape. I'll show you the picture. So what we learn ultimately, ultimately we are getting a enlarged growth plate, which is causing widening of the growth plate, and that is giving uncalcified area in the epiphysis as well as in the metaphysis. With this background, let's look what happened in X-ray stage by stage. So in the early stage, acute phase, in the epiphysis we get cloudy area. It's a cloudy area. Why cloudy? Because it's not getting calcified. It may get more than one center of ossification. The bones are not getting ossified. So number of ossified center may be more than one also. And metaphysis looks splayed out. Why splayed out? Because it is not getting calcified. Okay, that you can see here. You can see the appreciate. Okay. Then we talk about stage number 2. This was the early stage. Now we talk stage 2, which is established. Vitamin D deficiency has been, bony are involved, and now it is established that bony abnormalities are there. Epiphysis again irregular motile, as we saw previously also. Metaphysis is rect broader. And now periosteum is normal if bowing is present thicken on the concave side. So at one side periosteum is thick and other side it may be normal. So we are getting periosteum thickening we are getting. Okay. Stage 3 is the stage of repair. Shadow become denser in the epiphysis because now it is going into stage of repair. Dense line at the end of metaphysis due to deposition of calcium. Remember, it's a repair state. In the repair state, calcium phosphate is trying to get it deposited. And now epiphysis is more clearly outlined, and there is a marked difference in the size between end of shaft and epiphysis. Epiphysis and shaft length will. So what you need to remember this? Not at all. Just remember the early stage, then stage of established, stage of repair, and finally completely repaired. Increase width of metaphysis. It is completely calcified. Normal calcium content will be there. Normal calcium content will be there. This you can see very nicely in these X-rays. Bone biopsy, rarely done. Rarely. We can do the tetracycline labeling test, again not needed, but this you should know. There is something called tetracycline labeling also. This you can see. We give tetracycline and the tetracycline binds to the bone, especially the growing plate. Look into this. First of all, the trabeculae are totally broken. These are the trabeculae, and now you can see they are broken here, right? The problem is in the trabecula in the bone, and similarly, normally the trabeculae are attached to each other here or totally broken down. And if you do tetracycline labeling, you can see very thin layer. You can see very thin layer of the tetracycline which get attached to the growing bone. Okay, thin layer, that means very little amount of little amount of calcification is there. Because ultimately it's going to bound to the calcification. The no calcification, thin layer of tetracycline binding will be there. But they are just for information that tetracycline labeling is done for the bone growth. Now it comes the beautiful picture that shows everything. bowing of the bone, indistinct epiphysis, wide growth plate, cupping of the metaplasia, and splaying of metaplasia. That means splaying means it is irregular surface. So friends, there are two things in metaphysis: cupping and splayed metaphysis. Widened growth plate, epiphyseal is indistinct, and bowing of the leg. That's the X-ray finding of a case of rickets. You have to remember this much only. Okay, previously I've shown you picture, but pictures may not be, but this you should remember. In the exam, they will talk about this picture only. So you should know the basic concept about X-ray finding. But one thing more, earliest abnormality to occur is in the lower end of radius and ulna. The wrist joint is the first thing X-ray to be done. For the first thing to be done is wrist X-ray. Differential diagnosis for infantile type of ricket is congenital syphilis, which is very rare nowadays, even scurvy, which is due to vitamin C deficiency. But these are again very uncommon disease are there, but vitamin D deficiency is still a very common problem. So how to treat? The good source of vitamin D are fish liver, milk and cheese. Cod liver has very high amount of vitamin D, cod liver oil, and sunlight exposure. Cereal contain phytate. They hamper calcium absorption, and you have to give supplement for a routine patient. But if the patient is really deficient in vitamin D, then you have to give high amount of vitamin D. Loading doses you have to give so that the recovery occur very fast. This you can see classical bowing of the leg, and this patient 2 years after giving treatment of calcium and vitamin D, you can see the picture bowing has totally disappeared and the child is fairly well. Deformities we can give by splints. Various types of splints are given to the child, especially this child. Suppose this child to whom we started treatment, but it will not become all right in 1 day or 2 days. But we want to prevent deformity. We like to give him splint so that further deformity do not occur because bones are very weak. Now for treatment of established deformity, again you can splinting or we can do osteotomy. Osteotomy, you remove a part of the bone and you make the proper alignment. So the two keywords are splinting and osteotomy in this particular slide. What complication can occur in this? Chronic skeletal pain. You remember in rickets there is bony pains with deformity, skeletal deformity, and finally fractures can occur without any cause because the bones are very weak. Now let's talk about other types or other cause of rickets. So one more thing, whenever they talk about rickets, unless specified, it means they are dealing with nutritional type of rickets. And again, the key word to remember in nutritional type of ricket, there will be secondary hyperparathyroid, low calcium, low phosphate, increased PTH. This is the universal question. Nutritional variety of low vitamin D, there is secondary hyperparathyroid, low calcium, low phosphate, increased PTH. This question come in all the exam. Okay. Now, other condition which can lead to ricket, anti-epileptic drugs. what they do, they induce the microscopic enzyme P450. The anti-inflammatory drug, they are enzyme inducer. So they are the enzyme inducer. So they decrease vitamin D level, and that can lead to seizures. Why? The point I discussed, vitamin D deficiency will lead to hypocalcemia and frequent fracture. All due to low vitamin D, low calcium. There is a generalized feature of, so here also they will also having generalized bony problem, which is a feature of low nutritional. Tumor related hypophosphatemic rickets, something very interesting, not very well read by most of students. So there are certain tumors which are causing hypophosphatemia, which is causing rickets. We learned in the basic concept that we need both calcium and phosphate to get calcification in the bone. It's a calcium phosphate which go and get a deposit. But here tumor is causing low phosphate level. Okay, tumor. So this will lead to or oncogenic hypophosphatemic osteomalacia or rickets, depending on. Oncogenic because it's a tumor. It is causing loss of phosphate in the urine. So it's oncogenic hypophosphatemia, osteomalacia or rickets, depending on whether it is occurring in a child or in an adult. Both can, in both cases, can lead to hypophosphatemia. What are the tumors? Notorious neurofibromatosis, fibrous dysplasia, osteoblastoma, and angiopericytoma of bone, skin, and tumor. Neurofibromatosis, so-called NF, fibrous dysplasia, osteoblastoma, and hemangiopericytoma. Okay, so these are the ones which can lead to oncogenic hypophosphatemia. What they do, how they are going to cause hypophosphatemia, these cancer, they they reduce phosphate reabsorption. So definitely there will be phosphate will be lost in the urine. So phosphate will be lost in the urine, so that lead to hypophosphatemia. So there is loss of phosphate in urine. So treatment is remove the existing tumor. Unless you remove the tumor, it will not get cured because it is constantly secreting phosphate. Renal osteodystrophy, the point which I discussed earlier, however, a brief, this occurs in condition where we have chronic kidney disease. And do I need to tell you that it will hamper conversion of 25 to 125, hydroxylation will not happen. Okay, so this can happen in chronic renal failure in children due to whatever cause it may be. It can be a kidney disease, maybe due to congenital abnormalities. Polycystic kidneys can lead to kidney problem, and that can lead to secondary hyperparathyroid. Okay, so in chronic renal failure in particular, secondary hyperparathyroid, and this lead to increased activation of osteoclast. Why? Increased PTH. Increased PTH will lead to secondary osteoclast activation, and they will try this increased amount of PTH will try to resolve calcium phosphate from the bone to plasma, and this is known as high turnover disease. This is known as high turnover disease because of high amount of PTH. It tend to withdraw calcium and phosphate from the bone, hunger, high turnover disease. So mechanism I briefly mentioned to you when I discussed renal osteodystrophy. However, Glomerulus are not able to excrete phosphorus. This happens in chronic renal failure. Vitamin D production is reduced. This is seen again in chronic renal failure. Calcium absorption from the GIT is reduced again due to uremia, which can lead to reduced small intestine, and as well as there is vitamin D deficiency also. They all lead to reduced calcium and phosphate resorption from the GIT. Well, PTH triggers. Now, PTH, high amount of PTH is there, and that lead to bone demineralization. Why? High amount of PTH increases osteoclast activity, and that lead to demineralization. And excess of this calcium get precipitated in the cornea, skin, and blood vessel. Okay, so it lead to corneal opacities. So by and large, picture is same as a nutritional variety, and there is secondary hyperparathyroid, and you treat calcium, vitamin D, growth hormone can be given, and for any bony abnormality, we can go for osteotomy. This so-called uh, Illy-Zarov type of this a technique has come. About 3 decades came, they do osteotomy by the technique is there. But do you need to know? No, you just need to know osteotomy is done. So by and large, in all the cases, we have to supplement calcium, calcium and vitamin D. Okay. How we can prevent? Definitely good nutrition, vitamin D, sunlight exposure. Now we come to very important topic. X-linked dominant hypophosphatemic rickets. Can't afford to lose this topic. So it is X-linked dominant. Point to be noted very carefully. In the beginning, I told you that there is something called X-linked dominant. Let us see. And it is hypophosphatemic. This is also known as vitamin D resistant rickets. Point to be noted. So we can cause X-linked dominant or familial hypophosphatemic rickets. Also vitamin D resistant. Calcium level are normal. Point to be noted. Since the calcium level is normal, there is no sign of hyperparathyroid. No signs. But bone mineralization is defective. So there are 4 or 5 keywords, though lines are only 3. First keyword, second keyword, third, 4, 5 and 6. Oh, the 6 keywords. That's why I said it's a very important topic. Write down all the 6 points. Okay. What are basic pathology? Defective proximal tubular reabsorption of phosphate. So it means phosphate will go out of the urine. So there's one entity which is a pure phosphate deficiency rickets. Very important point. The problem is only of the phosphate. There's no problem of the calcium, PTH, vitamin D, nothing. Is all due to loss of phosphate. So that's why you are getting hypophosphatemic type of rickets we are getting. Remember, for it is the calcium phosphate together are needed. Even one component is there, other is not there, then it carry no meaning. There is no meaning. You got to have 2 limbs, just like you have a motorbike. There's a front wheel and the second rear wheel. Even we need to have both the wheels should be in perfect condition. Suppose the front wheel is punctured. Can you drive the motorcycle? No way. So any one tire is punctured, you cannot drive. Same thing here, the which wheel is not, phosphate is not there. So there is no ossification. Treatment, you have to give phosphate as a replacement therapy, maybe up to 3 gram. Okay, and we have to give large dose of vitamin D also to prevent secondary hyperparathyroid. Why? Because once you are giving phosphate, calcium is already there. Okay, calcium and we don't want that there should be secondary hyperparathyroid. We want to keep everything under control, but by and large, phosphate is the only major treatment. Rest everything to be controlled. We may give vitamin D depending on how much, but everything has to be monitored very carefully. Such cases you cannot treat blindly. Okay. Now we talk about that was vitamin D resistant cases, right? So now we talk about vitamin D dependent type of rickets. It is dependent rickets. We have type 1 and type 2. Type 1 is also known as pseudo vitamin D deficient ricket. We also call it to be pseudo vitamin D deficient rickets. Pseudo, not true. It is a autosomal recessive. Point to be noted, the previous one was X-linked dominant. Here we are getting autosomal recessive. Point to be noted very carefully. Now what happened in these patients? There is a mutation in the gene CYP27B1 gene. You may or may not remember the gene, not important. But you should know what the main effect. Because of there is a mutation in the gene which encode with 1-alpha hydroxylase. So this gene is mutated, there will be deficient when alpha hydroxylase. You just have to remember two things: recessive and 1-alpha hydroxylase deficiency. Only two. No need to remember the gene. Nobody going to ask you. So point is, in this problem is in 1-alpha hydroxylase. Even kidney is functioning normally. And in the very beginning, in the basic concept, I told you that for 25 hydroxylation to 125 hydroxylation which occurs in kidney, you need 1-alpha hydroxylate, and we need PTH. So in this condition, this is normal, this normal, but when 1-alpha hydroxylase is deficient, that deficient. So in this case, there will be no hydroxylation. 25 will not get converted into 125. So in this case, calcium so vitamin D will not form. Right? With the result, calcium will not be absorbed. Definitely there will be deficient vitamin. Vitamin D is deficient. Vitamin D is deficient, so calcium will not be absorbed. So this vitamin D deficiency is a genetic condition. So there will be feature of early feature within 1 year of the life. The patient will have all the feature will have within first year. Ultimate net result will be what? Low calcium, low vitamin D, and hypophosphatemia. Right? Why? There is a deficient vitamin D formation. The patient will have all the features mimicking like nutritional vitamin D deficiency. Okay. So these patients can develop feature just like vitamin D deficiency, and later on they can develop low calcium will lead to increased PTH. Why? They are developing secondary hyperparathyroid. So in nutshell, we can say very comfortably in these patients, classical finding, you are getting low level of 125 hydroxy level, but 25 this level will be normal. This will normal, this will be deficient. So we can very well treat, we can give vitamin D and patient will be all right. So that's why we call it to be vitamin D dependent ricket. So if I have to summarize, it is a, we call a pseudo vitamin D deficient. Number one. Number two, problem is problem of 1 alpha hydroxylase. This is essential to convert 25 to 125, and since it is deficient, 25 D3 level will be normal and there will be deficient 125 D3 level will be reduced. Treat by giving vitamin D. Now type 2. Okay. Type 2 is a very, very rare, extremely rare. It is again recessive. So it is such a low, the hardly only 50 cases have been reported, right? Not a, so nobody going to ask you. Nobody, but why I mentioned to you? In every book it is written, but it's extremely, extremely rare causes. So nobody going to ask you. However, you should know the basic concept. End organ is related to vitamin D. Ultimately, vitamin D is going to act at the receptor so that it can do its own action. Now, receptor is not vitamin D is coming, but receptor is not acting. Okay, so definitely in these patients, vitamin D will not be able to work despite having normal vitamin D formation. Vitamin D will not be able to act. So they again manifest within first 2 years of the life. And one more feature in these patients, alopecia is the classical thing that we see in large, and that is a marker of severity also. That means difference between type 1 and type 2 is alopecia. Alopecia is there, there's marker. However, you can only treatment is very high amount of calcium and vitamin D. Okay, so nothing special about it. So what you have to remember is alopecia. So keyword are that vitamin that problem is here. Vitamin D is calcitrol. Vitamin D is not able to act at the receptor, and alopecia is a feature. Alopecia is a feature, and finally we have to give only very high amount of vitamin D so that very high amount of vitamin D will try to have some action. So by and large, a quick recap of the last minute revision point of all types of rickets. Calcium is usually low, but it may be normal. Phosphate is reduced in all except renal osteodystrophy. Very, very important point. ALP, alkaline phosphatase, and PTH level are usually high in all. 25 hydroxy vitamin D level is normal or high except in nutritional variety. Remember, 25 hydroxy is what is being made in the liver. That is normal except in nutritional type. And 125 is normal low except vitamin D dependent, where it is insensitive to vitamin D. Osteomalacia. Majority of things I have discussed pathophysiology, and I also mentioned that in case of rickets, the problem is it's in the in the growth plate, and here is a bone matrix. And I also mentioned in the very beginning, there can be one patient can having both rickets and osteomalacia. Rest every pathophysiology is same, everything A to Z include. Okay, so now I can only briefly mention what is essential. Okay, one thing is there, it's a disease occur in elderly person. Again, the point I mentioned here, osteomalacia actually means the bone is soft because of vitamin D deficiency. Why? There is defective mineralization of the bone. Pathology, inadequate mineralization of osteoid. Okay, so and we also know that in the basic anatomy, in the bone we have a cells, we have a organic matter, we have a inorganic matter, which is calcium, phosphate, apatite. Okay, this is inorganic component and it is about 70%. This is around 25 to 30%, 4 to 5% water is also there. The major chunk is by the inorganic salt, and that's why in ricket also the inorganic salt is not there. Bone growth could not happen. Here the again we have made a wall of brick but without any cement. Same thing, we are making a bone without any cement. That's why the bone are weak and they are difficult, they are not mineralized. Symptoms usually occur above the age of 50 years. Bony pain is a classical feature. Bony pain was in case of children also, ricket also. It was bony pain with deformity. Here we have bony pain with muscle weakness. Easy fracture was a feature of both the condition, ricket as well as osteomalacia. What we get is looser zones. Let me rub out so that you can see better. Yeah, now things are much clearer to you. Again, looser zone. I can enlarge the picture for better visibility. Cod, fish liver, or vertebra, codfish with vertebra. Trefoil pelvis. Scan, bone scan, you can see increased amount of osteoplastic activity going on, and that you can very well appreciate in bone scan. Okay, and due to this reason ALP level is high, alkaline phosphate level is high due to this reason. Treatment, sun exposure, supplementation and good diet is the answer. Okay, thank you very much. God bless all of you.